Yes, sir, you can start.
Hello. So very good afternoon. This is dietitian and diabetes educator Aurithro Khan, and also clinical nutritionist and cardiology and renal nutrition specialist. I'm attached with KPC Medical College and Hospital Clinical Nutrition and Dietetics Department as an case nutrition faculty and examiner, and also academic counselor and assistant professor of Indira Gandhi National University, Open University. So IGNU, all you know very well. So today I have given a topic regarding diabetes, the control of diabetes, and also the resistant starch, how resistant starch work for the diabetes population is a very important thing. So first we should know that what is diabetes all about. So diabetes is basically all we know. This is a metabolic disorder. Diabetes is nothing but a metabolic disorders. And if we want to know the type of diabetes, then we know there are the various classifications of diabetes: type 1 diabetes, type 2 diabetes, gestational diabetes mellitus, and malnutrition diabetes. So type 1 diabetes we all know very well, that is insulin dependent diabetes mellitus, where insulin is functionally not active, insulin is not working properly. In that cases, type 1 is basically a insulin dependent diabetes mellitus, and type 2 basically used to call non-insulin dependent diabetes mellitus. For the certain point of time, if diabetes is not controlled, then can endocrinologists and diabetologists can try to introduce insulin injection. But before that, with the medications and the dietary modification, lifestyle management is the key to managing type 2 diabetes mellitus. And what is gestational diabetes mellitus, used to call the GDM? So this is basically during gestation, 20 to 28 week of gestation. If a pregnant mother fall into diabetes, is called the gestational diabetes mellitus. And another is the malnutrition diabetes mellitus, which is very used to call, because in diabetes is a metabolic disorder, and there is a lot of research has come up to put controlling and managing to combat with diabetes. Medicines is there, insulins are there, lifestyle modifications and dietary modification is one of the holistic approach to manage diabetes mellitus. So in that cases, how come? So today's topic is how come resistant starches, how come resistant starches came to this picture to control and manage diabetes. So in that cases, please allow me to share the screen, then we can go in detail how can resistant starch manage diabetes mellitus. So let me allow to share the screen. Hope my screen is visible. So today's topic is resistant starch and a few of Lente carbohydrates in diabetes management. So again, my introduction is there. You all get to know who am I. I'm a dietitian, Aurithro Khan. Once again, welcome to all of you. So already I've discussed what is diabetes. So diabetes is a group of metabolic disorders. This is characterized in increased sugar levels. It basically used to call the hyperglycemia, and this is a chronic metabolic disorder. So basically, in cases of diabetes, we are managing through medicines, through insulin, through lifestyle modification, dietary approaches, exercises, diabetes education, insulin technique, food care management, eye care management, and also to educate our people. That's why nowadays we people used to call us dietitian and diabetes educator. So diabetes educator have a versatile role to manage our diabetes, not only diet but also insulin regime technique, medicines timing, drug nutrient interaction, food care management to cope up with the diabetes and to our positive approaches, how to make a holistic approaches to a person, because one a patient is always been a patient. For patient and being patient, we should call ourselves and we should act empathetically with the patient to give the positive vibes, not the negative vibes to the patient, because patient is already been to a negative part, because patient is suffer from diabetes, maybe other comorbidities like diabetic nephropathy, diabetic cardiomyopathy, diabetic neuropathy, diabetic foot, and lot of problems. In that cases, we should always encourage and always give to positive vibes to the patients. So now carbohydrate is a very bigger part of role. How carbohydrate provides, a diabetes mellitus, in that cases, how carbohydrate make a bigger role, because we all know the digestibility of the carbohydrate and the glycemic index is markedly influenced, and the glycemic response in high consumption of the dietary fiber in essential and beneficial for managing the diabetes mellitus. So if the structure of the carbohydrate, there are several types of carbohydrate. There are simple carbohydrate, basically used to call the glucose, fructose, galactose, and complex carbohydrates are there, oligosaccharides, polysaccharides, all are there. So this is a very versatile role in the mixed platter of carbohydrate. There is a chance to patient keen to have, not tend to have the carbohydrate when suffer from the diabetes. This is absolutely wrong. When you are not having carbohydrates, if carbohydrates are not there, then the fats, the stored fats will break down. If the stored fat will break down, ketone bodies will form. You must have heard diabetic ketoacidosis is a very common phenomenon if a person is not have the sufficient amount of carbohydrate. If you can follow my slides, you can see carbohydrate provide 65 to 75% of the calories across all regions of India. Basically, we to encourage to have a good amount of the dietary fiber, soluble dietary fiber and insoluble dietary fiber. The role of the soluble dietary fiber like pectin, like mucilage, to make a gel form, to a chilled form, to have the the insulin sensitivity, to reduce insulin resistance. If insulin resistance is reduced, then diabetes automatically will be controlled. But in cases of the dietary fiber is essential, in the cases is sugars may have a very beneficial effects of the glucose metabolism. So if we talk about the glucose, if we talk about the glucose metabolism, so thereby increasing the risk of the developing of the type 2 diabetes in the presence of the genetic dispositions of making in the glycemic control is more difficult to achieve a people with established with type 2 diabetes mellitus. So dietary fiber, resistant starch, Lente carbohydrates are important for managing diabetes mellitus. Now, what is resistant starch? So resistant starch basically a such type of starch we used to call, this is a complex carbohydrate. This is, you can say, the polysaccharide, non-starch polysaccharide that resists digestion in the stomach. So basically, resistant starch first established is its year about 1970 to 1982, and it's coined by scientist Englist et al. Is basically a starch is different. Resistant starch are basically a proportion of the starch is ingested through, it's not digested through the human enzyme. Basically, if we talk about, if we recollect about, or if we review about our alimentary canal system, first we have to take any kind of food through mouth, from mouth to esophagus, to esophagus to stomach to small intestine, then it will absorb to the GLUT1, GLUT2 receptors, villi in all the parts, and the large intestine. So in that cases, resistant starch, that's with resistance because it's not absorbed in neither in the stomach nor in the small intestine. It reaches directly to the large intestine, the large colonic part, undigested form, where it has shown act to the carbon substrate for the beneficial bacteria, making resistance form to form the dietary fiber. So basically this is the fermented by the intestinal microbiota. Is basically intestinal microbiota is a fermented. So how it's a fermented? So basically the procedures, the mechanism of action of the resistant starch, the production of the starch degradation is not absorbed in the small intestine of the healthy people. It enters the large bowel where it fermented by the microflora and with the short chain fatty acid. So short chain fatty acid basically the end products of the resistant starch. So what are the short chain fatty acid? Short chain fatty acid are propionate, short chain fatty acid is acetate, and the butyrate. So short chain fatty acids are taken up by the large bowel and used for energy. So one of the major short chain fatty acids are butyrate, appear to have a key role for promoting normal phenotype in the colonic epithelium. The resistance is a combination of the potential health. So basically, if we talk about the symbiotics like probiotics and prebiotics, now after the fermentation in the large intestine, it acts as a prebiotic. It acts as a prebiotic. We all know prebiotics are the food for probiotics. What are the probiotics? Probiotics are basically good beneficial bacteria, bifidobacterium, lactobacillus. So this is a very good bacteria. So is a resistant starch and acts as a probiotic. So healthy gut bacteria can improve glycemic control. So basically why it's improved the glycemic control? Because the thing is that is a slow absorption. If stomach to small intestine to receptors GLUT1, GLUT2 and large intestine, so the progressions are very slow. If the slow progressions are there, is automatically sensitize the insulin and automatically reduce the insulin resistance. So this is the way they are basically controlling the diabetes and the blood sugar mechanism. So in that cases, what are the food sources? Basically raw potatoes, green bananas, ripened bananas, beans, peas, lentils, all are whole grain cereal, oats, cooked oats, all are basically the classical examples of resistant starch. Now if we come to know about the different classification of resistant starch, the resistant starch 1, resistant starch 2, resistant starch 3 and resistant starch 4 and 5. There are 5 types of different structural resistant starch are there. So resistant starch is a physically inaccessible starch found in particularly meal grain, legume. This is resistant starch 1, and resistant starch 2 basically plantain flour, tender jackfruit, raw potatoes. This is resistant starch 2. But there are a thing is called the starch retrogradation. So what is starch retrogradation? If we talk about the starch retrogradation, then basically this is a cooking, cooling and reheating. So cooking, cooling and the reheating, these 3 are basically the starch retrogradation. So one type of resistant starch is formed when foods are cooled after cooking, and this process is called the starch retrogradation. So it occurs when some starches in case is their original structure due to heating or cooling, and it again restructures after later cooled and its new structure is being formed. That's why cooking, then cooling and reheating will give a new structure that resistant starch will occur thoroughly. So potatoes, rice, barley, cooked beans, all are very good and classical examples of the resistant starch. So basically these all are starch retrogradation and will have a tremendous role for controlling diabetes and blood sugar control. So this is a very important thing that we can control with our through the resistant starch. So proposed mechanism by which resistant starch reduces the glycemic response, the capacity to form the viscous solution, lower viscosity basically, inhibiting lipase activity and delayed gastric emptying. So let me come up and let me shed the light on in this picture. So one positive mechanism that may modulate the insulin sensitivity and change in the fatty acid formulation in the colonic process. So these acids may have a stimulatory effect on the production of the hormone associated with the insulin metabolism. So basically these are glucagon like peptide, GLP-1 and peptide YY, peptide YY. So in studies suggest that the proliferative effect of this resistant starch consumption of enhances the insulin activity and sensitize the insulin role, and also reducing the ectopic adipose tissue and regularize the adipogenesis. So this is a very good thing that we can see the how come the GIP which passes through the pancreas causing the beta cell to secrete insulin. So always is a knock to the beta cell to secrete insulin to control diabetes and the presence of the glucose and the free fatty acids, because I always told that the free fatty acid formulation like acetate, propionate, butyrate, we know these are the short chain fatty acid, but apart from that there is a several free fatty acids are there in the ileum, stimulates the release of enteroglucagon and this to increase the insulin release. So this is very good for the release of the insulin and also the insulin activity. And if we go back to the previous slides where we can see when studies, there are several studies, several Japanese studies, Indian studies also been published that the effects of resistant starch on the postprandial glycemia and the insulinemia have been extensively studied, and this is known of the resistant starch of the fat metabolism, and the study examined the relationship between the, because we all know the beta oxidation, omega oxidation, we know the hepatogenous de novo synthesis. How come? Because after acetyl coenzyme, melanin coenzyme been formed. After melanin coenzyme, this the single glyceride, monoglyceride, diglyceride, triglyceride being formed. So this is the all cycle through the acetyl coenzyme. We can convert into energy. We can form to the energy conversion, and another side we can go for the cholesterol. So if triglycerides will high, then the lipid profile will be destroyed. It will be depleted, and a lot of problem can occur. So this is the main thing. This is the main thing after the pyruvic acid cycle, glycolysis cycle in the mitochondria, Krebs cycle occur. So from the acetyl coenzyme, we try to restrict to form the triglyceride, and we try to give the energy formation. So energy formation will be the key side, for maintaining diabetes mellitus. So this is a very helpful for the people for maintaining diabetes mellitus through the resistant starches. So resistant starches, again I am saying lot of food, lot of food like oats, like brown rice, normal rice, like banana, all things are very good amount of resistant starch that also not only to control the blood sugar but also increase the filling mechanism kind of thing, because after having the dietary fiber, soluble dietary fiber, we can get a very good satiety, decreases the cholesterol, reduce risk of the cancer, and resistant starch is fermented slowly and causes the less gas than the other fiber. Because I do always know that resistant, after having the resistant starch, there's the hydrogen, there's the methane, there's the carbon, all things are being formed, but this is safe rather than other dietary fiber. So resistance and gas formations is there, definitely is there, but this is very slow, and this is very the chances are very lower than the other dietary fibers. So this is all about the resistant starches, already been discussed. So benefits I have already discussed: increase the feeling of fullness, treatment and preventions of the constipation, decrease in the cholesterol. We all know the story about the cholesterol formation, the chelate formation. So this is very good for the dietary fiber, where the cholesterol can't go for making the atherosclerosis and all, is directly go to the feces and reduce from your body, reduce risk of the colon cancer, because we know we Indian are not too much of susceptible to have the diverticulosis colon cancer like the other countries, because we are having lot of shags, lot of green leafy vegetables, lot of fruits, lot of foods, and lot of vegetables, because the outer parts of the vegetables, basically the cell wall side, the cellulose, hemicellulose, the insoluble dietary fiber, the inner sides basically have the soluble dietary fiber. And resistant starch is fermented slowly, so it causes less gas than the other dietary fibers. So we'll not discuss too much of the Lente carbohydrate, the same as the resistant starch, but the altogether the flatter postprandial glucose profile, lower mean insulin level postprandially, and we can see the good amount increase of the C peptide. So C peptide is basically a kind of a test, enzymatic test. We can see how insulin is functioning basically. So if C peptide are low, basically insulin resistance. If C peptide is high, insulin works smoothly. Reduce urinary catecholamine output, lower fasting at postprandial serum total and LDL cholesterol level. Already I have discussed. Reduce hepatic cholesterol synthesis. We all know that basically hepatogenous diabetes, where de novo synthesis with the hepatocyte cell leads with the diabetes mellitus, because we have discussed about the de novo synthesis biochemistry, where the acetyl coenzyme, 2-malonyl coenzyme, 2-monoglyceride, diglyceride, triglyceride is formed. So this hepatic cholesterol can be reduced, lower serum lipoprotein B level, lower serum uric acid level, because we all know rather than purine, glucose and fructose metabolism is much more higher to form the uric acid level. That's why we try to always restrict high fructose corn syrup, all the outside packaged drink, aerated beverages, carbonated beverages, all these have a very high amount of the high fructose corn syrup. Because if we talk about the resistant starch, if we talk about the amylopectin and amylose, a very good amount of polysaccharide are basically resistant starch. These are the helpful rather than this glucose and fructose. Increased urinary uric acid excretion. Definitely drugs are there, but too much of water, too much of good amount of resistant starch are increased urinary acid excretion, uric acid excretion. So studies, there are a lot of studies yet to have. Studies stimulated by the fiber hypothesis have emphasized the positive modification of the gastrointestinal events by dietary means, incorporating the dietary fiber like resistant starch, lead carbohydrates, the very good amount of the good source of the carbohydrate, because we shouldn't restrict carbohydrate. In a diabetic patient, always tend to have the balanced nutritious diet, 60 to 70% of carbohydrate, 20% of protein, and 20% of fat. So carbohydrate must be there in their diet, and subsequent rise in the blood glucose level. So key message to all to the learners and the delegates and the other spectators, that experts have advocated increasing carbohydrate intakes together with increasing the fiber content of the diet. However, the increase of the carbohydrate intake should be seen an encouragement to take the high fiber slow release carbohydrate, because resistant starch itself a slow release carbohydrate, unlike other carbohydrate. Other carbohydrate basically in the small intestine, in the stomach, their enzymatic activity starts with the help of the enzymes, but resistant starch does not. Foods are the more the refined carbohydrate foods. When increasing the fiber intake, go slowly and drink plenty of water to reduce the GI side effects. Remember, all types of fiber have health benefits. To eat a variety of fiber containing foods, all the dietary fiber have a very good amount, of role. A role is so important to make a proper diet, proper dietary modification, and also the blood sugar control. Look, blood sugar is one of the major components. The diabetes is major component, but comorbidity, like comorbidity are there, like diabetic nephropathy, diabetes retinopathy, diabetes cardiomyopathy, diabetes related heart failure, diabetes related neuropathy, all are very common. And the drugs are there. Several drugs have the several mechanism. There are the if you talk about the biguanides, if you talk about the like other drugs like DPP4 inhibitors, different drugs have the different role with the organs, like with the pancreas, with the small intestine. So these are should be, we can come up with the solution with a good amount of the dietary fiber in our diet for maintaining and control the blood sugar level. So future perspective to research, more work and research are needed to define those foods and classes of foods that are most effective, will allow the formulation of diet acceptable to the majority of those with diabetes. More studies should be done on factors like the nature of the fiber or presence of the enzyme inhibitors, protein starch interaction to others determine. Also, the effect of the food must be assessed by the direct physiological testing until sufficient evidence is available and comprehensive analysis have been developed. Basically, if we talk about the bioavailability, if we talk about the good sources, but definitely we could depend on the outer dietary sources. Nowadays, lot of nutraceuticals like pharmacology and nutrition has come up. We might depend on those. Basically, foods are there, vegetables are there, but due to the bioavailability concern, we can depend on the outer dietary sources. So that's it for my presentation. So if any questions so far, I'm just stopping my screen sharing off. So if you have questions so far, please ask me in the chat box. Is anybody there to volunteer me, Mr. Arnav? Any question, please? Okay, no questions till now. Okay. Okay, there's no questions till now. If any questions come up in your mail, so I request to all my Sun Pharma friends to please jot down all the questions and let me know. So definitely I will give one by one answers. So thank you once again to Sun Pharma Prohance D division for inviting me and making me a part of this empirical session to discuss about resistant starch and diabetes. Thank you. Good day to all of you. Thank you.